I'm Andrew Brenner with UT Health San Antonio. I'm here today with Dr. Nolan Priedigkeit from Dana-Farber Cancer Institute. Today he gave a wonderful talk on fusion RNAs and metastatic breast cancer. Dr. Priedigkeit, so I had a couple questions. Well, we know that the breast cancer, especially as it gets further along in the progression and multiply metastatic, it has significant chromosomal instability um, and highly aneuploid. You were able to identify very specific founder fusions in these tumors. Can you briefly summarize those findings that you presented today?
Yeah. So, as you mentioned, breast cancer is very unique among epithelial malignancies in that it has probably the highest number of structural variant breakpoints among the most common epithelial malignancies. And occasionally, this can bring two genes that are normally far apart closer together and produce a fusion gene. And we had evidence that, ESR1 or estrogen receptor fusions may be driving therapy resistance in the advanced setting. So we set to characterize the landscape of fusion RNAs in metastatic breast cancer a little bit more thoroughly. So in order to do that, we sequenced over 400 samples from patients with metastatic breast cancer. And we used what we feel is a rigorous fusion finding method and called fusion RNAs in the disease. And as you had mentioned, we found differences in subtypes. So basal breast cancer harbored the most fusion RNAs per tumor, followed by HER2 enriched, followed by the more proliferative subtype of HR positive disease, LUM-B. And some of these were actionable, and we can talk about that maybe in a little bit.
Yeah, so I think that one of the exciting findings was in the luminal subtype, the ESR1 fusions.
Yeah.
And that certainly seems like it could be actionable potentially.
Mm-hmm.
I guess one thing that comes to mind for a lot of providers would be, is there a way that this could be actionable in the clinic? I'm sure there are some technical challenges with detecting these fusion RNAs. Could you talk a little bit about that and the reality of this actually making it to the clinic someday, being able to detect these?
Yeah, so firstly, I think it's a little too early to say, to kind of implement at least fusion finding for ESR1 fusions in particular, broadly in the clinic, simply because we don't have necessarily much evidence of a drug or compound that we can use in the ESR1 fusion positive setting. But nonetheless, I do feel that we need to think a little bit more cautiously about how we detect ESR1 fusions. In our study, we found them to be present in about 5% of HR positive treatment refractory metastatic breast cancers. And the first step in order to kind of understanding them better is really kind of building, larger clinical cohorts for these rare fusions so that we know kind of what clinical context they arise in and what kind of therapies they respond to after patients develop these fusions. And then hopefully that'll open the door kind of for preclinical investigations of compounds that may be efficacious against them. One of the key points is that the ESR1 fusions tend to lose the ligand binding domain, which is where a lot of our kind of current endocrine therapies and those in development bind to. So really, there are some companies that are producing small molecules against ESR1 that may bind outside this region. And these I feel might be the most promising for ESR1 fusion positive disease.
Great. So, and then I guess another interesting point was, while ESR1 fusions and luminal were the most recurrent for within a subtype, the numerically basal cell had the most fusions. And that is one that we do not have a lot of targeted therapies for. So we're very interested in finding anything that is potentially actionable there. Were there any particular ones that you found that might be important in basal cell that we might be able to go after?
Yeah, so unlike some of the HR positive fusions that we found, like ESR1, FGFR2, and BRAF, which could be potentially druggable with drugs that are currently in development, the basal breast cancer didn't have anything so striking that we have a drug in hand that we can test. But what was interesting is these fusions in basal breast cancers are cancer specific, meaning that they're not present in normal cells and they can be very highly expressed. So the idea and some of the things we're thinking about is perhaps we can use these fusion RNA breakpoints almost as like recruitment biomolecules for things that don't target proteins, but more like gene therapy advances, which is what we're currently testing. But it's a little bit too early to show any of that data currently.
Well, wonderful. Thank you again for a
you so
great
much.
talk today, and enjoy seeing the future work on this.
Thank you.